Welcome to Ask Dr. Geier Live, wherever you're watching. I hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help athletes and active people like you feel, look, and perform your best, regardless of age or injuries. Thank you so much for joining me on this Friday morning. Yes, I'm doing this an hour earlier than I normally do, and that came up very last minute. So if you somehow missed this and you're watching the replays, I apologize for that. I had something come up emergently that I was not going to be able to be here at noon. Hopefully, though, this works out for the majority of people. This is the one place, the one time that I answer medical questions. You'll notice on YouTube, those of you that spend a lot of time on YouTube, and if you subscribe to my channel and watch the videos, go down to the comments, I have been responding to more comments, but again, I'm never giving medical advice in response to questions. I have started using some of those questions as topics for videos that I'm in the process of creating, so you will see answers to those, but this is the only place where you say, hey, I'm going to ask a question and get my thoughts on it. Please understand, this is not medical advice. I have not seen you, haven't examined you, haven't looked at x-rays, MRIs, any of that. Legally, I cannot give you medical advice online. No physician or orthopedic surgeon can. What I can do is discuss that topic, whether it's an injury or surgery or rehab, recovery, some health and wellness topic, whatever it is, and give thoughts on that is not medical advice, but then you use that information to better understand what the orthopedic surgeon told you, or when you go see the orthopedic surgeon, you could say, hey, what about this? And then decide what options are best for you. So just please understand that I am not giving medical advice. All right, Georgia, Oh no! So Georgia is a frequent visitor on this show. Very, very cool person. At least it seems like. I've never met her in person. In Greece, I'm pretty sure. Question: dislocated index finger, second joint from the tip. I've gotten two opinions. One's to tie the finger in a position that I can use. The other one's to do an arthroplasty, change the joint with a new silicone one. All right, give opinions. That's really interesting. So I think, let me make sure I got this right. Second from the tip would be, let's see if I can show this here. So you've got what's called the distal interphalangeal joint, and then the proximal interphalangeal joint. And then there's the what's called the metacarpophalangeal joint. I think she's talking about the proximal interphalangeal joint. That is a problematic one, and I will tell you, George, I am not a hand surgeon, even though it's technically a field of orthopedics. It's not something, almost all of us in orthopedics that don't do hand, don't do any of it, and then the hand guys only do hand surgery. But there is a concern with a problem called a boutonniere deformity, and so if it's not treated appropriately, what they're talking about, I'm not sure what term you used, tie the finger, that essentially is sort of a buddy taping type of thing, in the correct position, and try to get what's called the central slip to heal. And if it heals appropriately, then it's no problem. The problem, a boutonniere deformity, is a long-term problem that can develop. If it doesn't heal correctly, you end up with basically this joint in this position and an inability to straighten it all the way out. Sometimes that is something that needs surgery. Typically that is not surgery to replace the joint. Typically that is surgery to basically reattach that central slip, that sort of tendinous structure that holds it in the right position. So you might, again, not medical advice, but given those options, I might see if there is a hand surgeon where you are or wherever anybody is, and see if that's truly the best option. I think that there, at least my knowledge of those injuries, and it's funny, this came up not all that recently. I'm a big Memphis Grizzlies fan, an NBA team. I grew up in Memphis, and they have a player going through one of those now, and he's out 6 weeks with that type of injury. So my understanding is he's not having surgery, but it is very, very important that that heals appropriately. So, and you are very welcome. Okay, so this may explain, now I think I may understand a little bit better, Georgia, and I apologize. So she has rheumatoid arthritis, that's how it got dislocated. That might explain the arthroplasty, because my first inclination is, why would you do a joint replacement on a joint that literally it's just a dislocation, gets put back in place presumably for a tendinous or a central slip injury. But if it was already arthritic anyway, all right, so people that were watching this and have a dislocation of that PIP joint, everything I said is worth talking about. It may not necessarily apply to her now that I understand the whole discussion. And I don't know if I put this on the screen. What she's saying, rheumatoid arthritis, the joint's completely damaged. So when you're talking about an arthritic change, when the bone and cartilage are worn out and that joint is subluxing out of position or maybe completely dislocating, then yes, sometimes a joint replacement can be an option, because typically your options in that scenario, especially if it's problematic, if it's painful, can't use it the way you want, are either to fuse it, not ideal in an index finger, which you use a lot for grip, or an arthroplasty. I will tell you, I don't know the success rates long term of that operation, but I know it is an option. Certainly if it's not, it's probably, again, not medical advice, but it is probably better than one that is completely useless because of pain or decreased motion or whatever it is. So hopefully that gives a little more insight. She's been to 2, and it sounds like hand surgeons, and I'm so confused. Yeah, that's a tricky problem, much more so than just a primary PIP dislocation in an unarthritic joint, in a fairly normal joint. That would be a different discussion altogether. So anyway, hope that helps. Any other questions out there? I'll stay a couple more minutes. What I will say, and I started it this week, and it will be for the next 2 or 3 months, I get so many questions given my background in anti-aging and regenerative medicine, my board certification in anti-aging and regenerative medicine, my certification in peptide therapy from A4M, the American Academy of Anti-Aging Medicine, and the International Peptide Society, so many questions on some of these non-conventional, some of these innovative treatments to help orthopedic injuries heal, whether it's peptides, that's a common question, whether it's exosomes, or stem cells, or PRP. So for the next few weeks, it'll be in my modern medicine playlist, but if you subscribe, you'll get notified I released a new video. Those are all going to be basically discussing some form of regenerative treatment for whatever particular injury is. Tennis elbow, Achilles tendinopathy, patellar tendinopathy, knee arthritis, hip arthritis. So if you're interested in any of that, definitely check that out. Yes, Georgia, fusing means basically you eliminate motion in that joint, and without motion it eliminates pain, but now it's stuck in that position. So it is kind of as much as it sounds. Chauvanoon, I don't know how to say that. 10 months post ACL surgery, hamstring graft. When I extend my knee, still have a weird feeling in the knee when I extend. Yeah, I don't have an easy answer. This is one of those that it would really be a better question for the doctors for the surgeon that performed it. There's a few things that you kind of think about. So the next time you go, you could ask about these. Is the graft actually serving as an ACL and it's now stable, or is there still some residual instability, whether that graft, and I don't know in her case, was this an autograft, meaning her hamstring tendon, or an allograft, or his, and was has that graft worn out, and is the knee stable, or is something else going on, maybe a meniscus tear or something like that, or you just haven't gotten full strength back. Generally, if one of my patients, and I've done probably 1,000 ACL surgeries in my career, came in saying 8, 9 months, 10 months, 12 months, it still doesn't feel right, the first thing I'm at least thinking about is, hey, you haven't gotten full strength back. And that's sounds like, oh, no big deal, but certainly for the people that don't do much physical therapy after surgery, I used to see that a lot, not just with mine, but people that would come to me after having surgery with somebody else and they weren't doing well, so they were getting a second opinion. So those would be the things. Strength or some other issue going on now, which you typically get probably what's called an MR arthrogram, where they inject a little bit of contrast into the knee and then repeat an MRI and get them back into an aggressive physical therapy program to see if that potentially is the issue. All right. Also, my knee used to be able to hyperextend. Now it can't go beyond 180 degrees for extension, for flexion. Passively have full range, can't do it on your own. Yeah, range of motion is really important to get early, especially full extension. The goal is always just to get it perfectly straight. We don't necessarily try to restore hyperextension, but if you can get it symmetrical, that's good. If you cannot get it all the way straight on your own, that is a very tricky problem to overcome more than about 6 weeks after surgery. Sometimes that needs surgery, but it depends on how much loss of extension. If it goes all the way straight with passively, meaning somebody else can get it all the way straight, generally that's tricky. And again, you try things like physical therapy, but range of motion is tricky to get. You want to get, for people watching this that are going through ACLs or will be going through ACL surgery, you want to get your full range of motion back as quickly as possible after that surgery. After about 6 weeks or so, it gets really hard. How soon should you get surgery if you rupture your biceps and have a full tear on the tendon? There's no necessarily right answer. I'm assuming we're talking about the distal biceps at the elbow as opposed to the long head of the biceps in the shoulder. That's sort of a different animal. Typically in older patients, but maybe it's the same answer. But definitely down at the elbow, I would ideally say within about 2 weeks, certainly not more than 4 weeks, because the concern is that tendon retracts up the muscle starts to atrophy, and it starts to get hard to pull all the way down to where it needs to attach. Could you get away with it longer? Yeah, potentially. But the key is to do it early enough you can do a primary repair and not need some sort of secondary reconstruction. And he says, yes, the distal bicep. All right, well, very good. Very good questions this week. Very interesting topic. So I hope this was helpful. Next month, I will be doing it a week early due to some other obligations I've got the last Friday of the month, but I will be there. I think it's February 16th, if I'm not mistaken. I will be on my normal time, 12 p.m. Eastern time. So if you missed it again, I apologize, but very grateful those of you who are here, and I hope you have a fantastic weekend. Very much appreciate it, and I will talk to you guys very soon. Take care.